We're taking this, 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 we're taking with a pinch of salt.
Dear colleagues, this is Dr. George Kosmadakis, nephrologist and host of today's ERA podcast, A Pinch of Salt. After a long period of stagnation, nephrology is actually facing one of the most exciting periods of its history. New pathophysiological and therapeutic pathways are unfolding daily, and the waterfall of new information is transmitted in every nephrology meeting nowadays. Proteinuria is a symptom of serious renal damage and a bad prognostic factor of renal survival. Its reduction or complete control are associated with better patient renal outcomes. A lot of new goodies are coming to help us to treat this condition. And I think that an ideal candidate could help us to understand more on this subject. And who else than Annette Bruchfeld, Professor of Inflammatory Kidney Diseases at the Department of Clinical Science, Intervention and Technology, Stockholm, Sweden. She is coming from Linköping University, and she's author of numerous papers on the subject and current chair of the ERA Immunonephrology Working Group. She is also active on the European Vasculitis Society. Annette, welcome to today's podcast.
Thank you very much for the invitation. So I just want to say that I'm professor in Linköping, but also professor at Karolinska Institute. So I work in two places.
So you are ideal to help us today with a lot of confusing matters concerning proteinuria. And my first naive question is, when should I measure proteinuria and when should I measure albuminuria? What is the difference?
Yeah, that's a very important question. First of all, if you want the definitions, like proteinuria and albuminuria are not exactly the same thing. So when you talk about proteinuria, that sort of indicates an elevated presence of protein in the urine, while albuminuria is more defined as an abnormal loss of albumin in the urine because of all the different pathogenic mechanisms. So albuminuria is very common. It happens, it's sometimes the first indicator of CKD and especially glomerular diseases. And it's typically present before you have a reduction in CKD. So it's also belongs to the definition of CKD. But you also have to have albuminuria. The definition is that you have to have albuminuria at least for 3 months to make sure that this is a real marker for kidney damage. And then there are different categories, a little bit, medium or much, and nephrotic syndrome. But proteinuria can be other proteins as well. So I think this question is very confusing. I think we're really considering how we use it in the clinic. I would say that when I started nephrology, we used to collect urine for 24 hours, and then we measured everything in the urine. And at that time, the patients were very good at collecting urine because that's what we asked them to do. And fast forward many years, now the patients don't know how to do this anymore. And we usually ask them to give a morning urine samples, and then we measure urine albumin creatinine ratio in most places, but there are still some places where you don't measure that, you measure UPCR instead of UACR. So at least where I work, we don't measure UPCR anymore. And if you really want to know what kind of protein, other proteins we have in urine, we have to do electrophoresis, which we do sometimes. I think the nephrology community has to be a little bit more stringent on this issue because it's kind of confusing in the studies, what kind of endpoints you choose. Some endpoints are UPCR, some others are 24 hours, and other are UACR, and they can't be compared exactly. And from what I understand, UACR is done in a pretty standardized way, whereas UPCR is not. It's done in, there are different methods. So it's not certain that they're comparable. But from what I understand, it's maybe cheaper to do UPCR in some places, and that's why it sticks around. So the KDIGO guidelines from 2012, they talked a lot about UACR, but now the new ones about glomerular disease, they talk a lot about UPCR. But I think that in clinical terms, UACR is fine. You follow the patient, you have some kind of idea what they start with and how it develops. And then for studies, we have to come to some kind of agreement what we actually use. Some places it's too expensive, so you can only use the dipstick. And you still have to remember that's also something you can use in case you can't spend much money on urinary tests.
So it depends on your means. It depends on the indications on the patient that you have in front of you.
Yeah.
And on the current practices.
Yes.
So is proteinuria a good surrogate marker for the success of a treatment?
Yeah. So just to start with what we really need, if we want to screen for kidney disease, we have to convince all our colleagues who don't work in nephrology that the most important thing is to measure a creatinine, and a urinary test of some kind to get some indication that there is the proteinuria, albuminuria. So if we ask them to do that, we have to be convinced that it is a good marker, not only for disease, but also for potential, to follow the treatment. So, and I think that the newer studies and there are like registry data talking about from Canada, for example, looking at albuminuria of a certain degree, that the rate of kidney failure is higher as compared to people who don't have proteinuria, but also from the clinical studies looking at outcome, where albuminuria, in most cases, which is used in most cases, can be translated into reduction in eGFR loss. So I would say that it's a surrogate marker for disease, but it's also a surrogate marker for outcome. And it can translate, if you're successful and you follow up the patients long term, it can indicate that you are better in terms of reducing eGFR loss, which is of course the most important for the patients and our practice.
And during the latest years, especially with the new drugs that are appearing, we are discussing a lot about lowering proteinuria. Is lowering proteinuria better in long term? Do you have data on this?
Yes, there is data on this. And it is, there are like observational data, but also the data from, I would say from the studies, even though they have a sort of composite outcome measure. It seems that, for instance, with the SGLT2 inhibitors, they do better with patients who have more proteinuria, but it doesn't mean that you don't have any proteinuria, very low proteinuria, that you don't have an effect. That's what's shown in the EMPA kidney study, for instance.
Right, right.
And then one more thing about proteinuria and albuminuria is that it's a marker for kidney disease and kidney outcome, but it's also a very strong cardiovascular risk marker. So you have to think of the patients long term, the kidneys and the heart.
Of course, it is also a cardiovascular marker. It's something we shouldn't forget, and the lower is the better. And if you can make it disappear, it's even better. And we see it more and more now. But before, with the elements we had available, we could be very happy if we had an improvement in a reduction in proteinuria. And now nowadays with the combined therapies, we see more and more patients with disappearance, which is wonderful news for us of a certain age. What is the rationale for pursuing lower proteinuria also in inflammatory kidney diseases? You are a specialist on that.
Yes. So when you think of inflammatory kidney disease, you always think about, I mean, the main thought is the inflammation. How do we manage the inflammation? That the inflammation is one thing, and then you have damage, long-term damage. So you have to think of patients with inflammatory kidney diseases as having, many of them end up with CKD, so they would have the same risk as everybody else, and you would have to treat them according to CKD, optimal treatment for CKD. So there has been an interest, and both in the DAPA-CKD and the EMPA-KIDNEY trial, they included quite many IgA nephropathy patients, and it was also pre-specified analysis. And they could show that they did very well with these drugs. You have to treat many things. I mean, there were many new drugs coming for IgA nephropathy, but you have to think about the long term, and these are young patients. But we have other secondary glomerular diseases, ANCA-vasculitis, lupus nephritis, and it's the same thought that perhaps it's not the thing you choose when they are very active, but for the long term, they will do well on these drugs as well.
Amazing. The indications are increasing every day. As a professor in ASN said, don't ask yourself where you can prescribe these drugs. Ask yourself where you cannot prescribe these drugs.
Yes.
So,
exactly.
it's giving me a good passage to the next question, because we have heard a lot about the effects of ACEs and ARBs and SGLT2s in the afferent and efferent arterioles, but it seems that there are some other effects that are protecting the renal function and reduce proteinuria. Can you comment on these categories of drugs?
We'll start with SGLT2 inhibitors on top of ACE inhibitors or ARBs. So we have like our patient with some inflammatory kidney or something else, and they would have a CKD, and they would have increased interglomerular pressure because they will have CKD with reduced nephromass or heart failure or diabetes, obesity, or whatever. And then you have the opportunity to try to lower the pressure by changing the arterial tone in the glomeruli from the afferent and the efferent side. And this is, I love teaching about this to the medical students. And they were like, oh, they know everything about intraglomerular pressure. But you can, with this combination, RAS inhibition affects the afferent, and the afferent is SGLT2 and the other is the efferent RAS inhibition. But combining these, you reduce the pressure. But there are, I think, from the first studies, we were like thinking, okay, how does this really work? And you just excrete all this sugar and sodium and all this, but it does a lot of other things. And you sort of reduce the elevated angiotensin and the reverse hypertrophy in the proximal tubuli. And what I think is most interesting personally is how it affects the tissue oxygenation, that they will have an effect on HIF and HIF sensitivity, and you actually have more erythropoiesis. And I actually learned this from one of the one of the clinical nurses. She called me and she said, this patient's hemoglobin is so high, what did you do? And this was somebody and I said, oh, I started SGLT2 inhibitors and EPO at the same time. That was a big mistake. So actually, what happens now, we realize that we can use SGLT2 inhibitors and wait to start EPO because it has an effect on hemoglobin as well. And perhaps that's an important effect also for the effect on heart failure for patients, cardiac effects.
So it's incredible that the effects are are are, are diverse to the renal anemia, to inflammatory disease,
Yeah,
anti-hyperplastic agents. It's wonderful. It's
yeah. It's
wonderful.
the drug that keeps on giving, as we say.
Keeps on giving. Well, can you comment a little bit on mineralocorticoid receptor antagonists?
Mhm. Yeah, so that's another kid on the block. So the MRA, so the one that is interesting, I mean, it's not that they're not interesting, the other ones, but the one that has been studied more extensively is finerenone, which is a more selective non-steroidal MRA. And it has a higher potency than the other ones, and sort of a strong effect on the overactivation of the MR. It has, at least this finerenone has a pretty modest effect on blood pressure, but it is pretty good at lowering proteinuria. And if you compare them, SGLT2 and MRA, the finerenone, it's actually better. It has a stronger effect on reducing proteinuria, but it does has a lot of effects, also anti-fibrotic effects, and it has also been studied with this both renal and cardiac endpoint, and is from the current KDIGO guidelines is second-line therapy for at least diabetic nephropathy. But I think that it will be used in many other diseases, our diseases, just once the studies are done.
Yes, that was my next question. I think we start always with diabetic nephropathy, and you see the a spillover effect on other conditions, and we finally give them in glomerulonephritis and other conditions. So, and the synergic effects are even more marked. I I have seen a few studies concerning this new category, the endothelin angiotensin 2 receptor antagonists, and I have seen very promising results from phase 2 and 3 studies. Can you comment on this?
Mm. So the fact is that we are very happy. We have these new drugs, RAS inhibition plus SGLT2, but there is of course a residual renal and cardiovascular risk,
Yes.
and that has been shown in all of these trials that we still have a heightened risk. So endothelin 1 contributes to vasoconstriction and the development and progression of both chronic kidney disease and also cardiovascular complications and lots of other things. And so this has been thought that this would be an attractive target to block. So the first study, I mean, it was the SONAR study that showed that endothelin A receptor antagonist atrasentan was reduced renal events in patients with diabetic nephropathy. As you say, we start with the diabetic, our sickest patients. And then we have moved on to sparsentan, which is a dual endothelin A and angiotensin receptor blocker that now is licensed in the USA to treat patients with IgA nephropathy after this duplex trial. Not the duplex trial, the PROTECT trial. And that the PROTECT trial showed that the proteinuria was reduced and eGFR was better in the ones who were treated with the combination as compared to those with only ibersartan. And then we have duplex trial in FSGS, and that has also been published recently. And there was a strong reduction in proteinuria, but the eGFR was unchanged over the 2 years of follow-up. So you can ask if should we follow up the patients longer, and they're doing a follow-up trial, so we will find out eventually. But in both these trials, they didn't receive SGLT2 inhibitors. There's an interest in doing other combinations.
Combination trials.
So there's been a trial from, I think it's sponsored by AstraZeneca, the CKD trial, where they randomize people to different combination, 2 different doses of this cibotentan, which is their endothelin drug, and plus minus SGLT2 inhibitor. And they found their endpoint was UPCR or UACR at 12 weeks. and they could show that the combination of this drug and SGLT2 inhibitor decreased the albuminuria significantly, and they also had 2 doses. And the problem with these endothelin drugs that they have been known for increased fluid retention, which is a problem if you have patients with also with heart failure or nephrotic, I mean, any kind of reason that they are overhydrated. And in the Zenit trial, the patients with the pro-BNP were not included. I mean, if they would have some degree of heart failure. So now there will be a phase 3 trial, which is called Zenit high proteinuria, and they will combine these 2 different doses depending on eGFR, plus minus. All patients have to be SGLT2 inhibitor, and they will find out looking at albuminuria and proteinuria endpoints. In this study, they use both, and the renal composite endpoint. This will be a long trial for 4 years, but I think it's important to really know how we can combine these things, and all these should be on RAS inhibition as well.
I remember the
interesting times.
Yeah, yeah, very interesting. I remember the period of Bosentan at that time with the problems, and you know there are more to come. And the period when we were prescribing the maximal tolerable dose of ARB or ACE inhibitor is over. Now we are going to combination therapies, to individualized therapies, and most exciting period in nephrology is starting. I'm very happy to be part of this during my career. Yes. Thank you very much. And now we will ask you 2 personal questions. Annette, we would like to know, if you were in a desert island, which book, luxury item, and 2 songs would you take with you, and why?
All right, let's start with the book.
Yes.
It's actually a book I want to read. I haven't read it for 30 years, but I would like to reread it. And it's from a Russian author called Mikhail Bulgakov, who was born in Kiev, but Russian speaking. And he studied medicine, actually, but stopped after the First World War, and he almost died from typhus. And he became an author about plays and things. And it was very difficult for him. He wanted to leave the Soviet Union for a long time because he couldn't work as he wanted. But he wrote, and this is the book I want to read, a book called The Master and Margarita, and I want to reread it. It's about, it's sort of a crazy story about the devil visiting Moscow in the 1930s, and about, and you understand, it's also some religious aspect, but you understand there's a criticism of corruption and this authoritarian regime. And I think this is interesting in our times. We can get some ideas. This book was actually published fully first in 1966, and I think there is a new edition coming out even in Russia, which I think is a little interesting. But so I want to read that one. And the luxury item, I'm really very much a music fan, and I'm going to bring my grand piano. The luxury, very heavy.
Piano.
I don't know how to bring it to. I don't know how to bring it to the island because it's really heavy. But we'll do that.
Like in the film, the piano, you know.
The piano, I'll sit
the
there
piano on the
play.
beach.
I'll play there.
Oh, wonderful. Yeah. What about the 2 songs?
So I'm a little bit old-fashioned then. I love music. I sing in a choir, and you know. So there's this French song from the 1871. It was popular then, called Le Temps des Cerises, which is a sort of love song. My parents used to sing it, so that's why I really like it. And then I think I would choose Bridge Over Troubled Water by Simon and Garfunkel. Wow. I really like that song.
Wonderful. Well, concerning Bulgakov, I think we'll have a fun association in ERA, because you're not the first one who talks about it. My co-host, Andres Kubernet, has talked in another podcast about it.
Yeah.
And when I was a student in Russia, I passed 6 months studying the work of Mikhail Bulgakov. I have read everything.
And he died of nephrotic syndrome. He died of kidney disease.
Yes.
So it's like, you know, and it seemed like it was a hereditary thing.
And Stalin liked to hate him and hate to like him.
They had a very complicated.
Complicated relation. So Annette, you live in Sweden, and we will come to at Stockholm in May, and we would like to have a secret address.
A secret address,
to go to it. We'll not tell anybody. Just
no.
Just between you.
I felt a little bit guilty because I knew about this question, and I was like, but I never go out to eat. I just work or sing in the choir.
Oh,
but
no, we go to eat.
And then I asked a few people, and then I actually went to a very nice restaurant myself in my brother's birthday. So it was a place called Freja. It's on the South Island, Södermalm. And it's like on the top floor, and you have a wonderful view of Stockholm, and they had really nice food. But there are many very nice restaurants, so I would recommend also to have lunch, because lunch is a fairly good option. It's not that expensive, and they always have very good food. So, but there are many very nice restaurants, and from all over the world, different kind of. And Swedish cuisine has become much better. And they compete in, these international competitions. But when you come to Stockholm, you should also enjoy the city, the nature. If you have time, you could take a boat to one of the archipelago, to one of the islands there, and spend a few hours there. That's also very nice. And I hope the weather is very good, but I can't promise it.
In 2008, it was wonderful. I was staying in a cabin in a boat just in front of the town hall, because I was a poor registrar.
Yes.
But it was wonderful.
Yes.
So, dear colleagues, that was a crash course on proteinuria by an eminent specialist on the field, and I hope you enjoyed it as much as I did. New podcasts on many interesting subjects are appearing every month. Bear with us in these monthly journeys through the fascinating landscape of modern nephrology. Check us out.